probably been, I would say, 4 to 5 years since JBI started this activity. And I won't go into detail about what gLocal means because every entity around the world, like ourselves, have received a 4-minute video which lays out what gLocal is. And so rather than me spend the time and then have you listen to the video, it will be the video that you will get. I think it's at slide number 6. And so I'm Marilyn McDonald. I'm your presenter and moderator today. And I know that you received an agenda for the day and know that between now and 1, largely it's information sharing, that being myself and my principal investigators, David and Rochelle Litvak. And yeah, I believe that you will enjoy the next little while with us. And okay, so land acknowledgement. Dalhousie is located in Mi'kma'ki, which is the ancestral and unceded territory of the Mi'kmaq people, and governed by the treaties of peace and friendship signed between the British Crown and the Mi'kmaq in our land. We also recognize that African Nova Scotians are a distinct people. Their histories, legacies, and contributions have enriched that part of Mi'kma'ki known as Nova Scotia for more than 400 years. And although I don't have it indicated here on the slide, we have an Acadian population in Nova Scotia as well. And of course, many of you would know that there was a deportation in 1755, or an attempt to deport all Acadians. And of course, many were, but many found their way back to Nova Scotia. And we have a vibrant Acadian community. So this slide, I just wanted to, this is Zoe Jordan, and Zoe Jordan is the executive director of JBI. And JBI International, the administrative seat or social seat is in Adelaide, Australia. And there are greater than 80 entities like ours that participate in evidence synthesis and in evidence implementation around the world. And it will be Zoe who will be doing the 4-minute video that you'll see shortly. And then just a very quick snapshot on JBI. As you can see, the WHO, a leading global evidence-based healthcare organization. And then what we're about, evidence plus education, plus software, plus research. And then the number of countries that have entities like we have are in across 40 countries. And just by way of information, there are 5 JBI entities in Canada, 1 at University of Victoria, 1 at Queen's University in Ontario, 1 at Memorial University in Newfoundland, ours in Halifax, and 1 at University of New Brunswick in St. John, New Brunswick. And of course, how JBI goes about its work in partnership with entities like ourselves around the world. And why? To improve health outcomes. And then a very crisp, easy to understand, but not so easy to do necessarily, vision and mission. Okay. This is the video.
Hello, everyone. I'm Professor Zoe Jordan, and I'm the Executive Director of JBI. And I'm delighted to welcome you to the JBI gLocal Solution Room for 2025. Whether you're joining us here in person or tuning in from across the globe, we're glad to have you with us. This week, something remarkable is happening in cities, towns, and digital spaces across the world. Researchers, clinicians, policymakers, and students from more than 60 countries are coming together, not in one location, but in many. And we're all here for one shared purpose: to advance evidence-based healthcare together. So what exactly is JBI gLocal? Well, it's a unique event series created by JBI, a global leader in evidence-based healthcare. Every year during gLocal Week, institutions and collaborators from around the world host events to share ideas, to showcase innovations, and to explore how evidence can be translated into better decisions, better practice, and ultimately better health outcomes. gLocal is more than just an event though, it's a movement. It's where the global and the local meet. That's why we call it gLocal, with a little g for global and a big local, because context matters. Now, why is context so important? Because as the JBI model of evidence-based healthcare suggests, evidence doesn't exist in a vacuum. You can have the most rigorously synthesized evidence in the world, but unless it's understood and applied in the real world, in your hospital, in your community, in your health system, it won't change lives. gLocal reminds us that local voices and global knowledge are both essential. One informs the other. Together, they drive meaningful, sustainable improvements in health. This week, you might hear from colleagues across different disciplines. You might hear about innovations in implementation. You might learn about new evidence syntheses or explore real-world challenges and solutions. Each event is unique, but they all have one thing in common. From Australia to Austria, from Cameroon to Canada, from Switzerland to Sao Paulo, we're looking to find solutions to using evidence to create a healthier world. Across all of these gLocal events, JBI collaborating entities have carefully curated a program that reflects the spirit of gLocal. You'll enjoy sessions designed specifically with your context front of mind, and opportunities to connect, to question, and to collaborate. And just like every other event happening under the gLocal banner this week, you will be part of a global chorus of people who care deeply about improving healthcare through evidence-based action. We encourage you to share what you learn this week, not just in the room, but online, in your workplace, and in your community. Use the hashtag JBI Solution Room to connect with others and to keep the conversation going. So once again, welcome. As I said at the start, you're not just attending a local event, you're participating in a global movement. Thank you for being here. Thank you for your curiosity, and thank you for your commitment to using evidence to make healthcare better for everyone, everywhere. Because that's at the heart of gLocal. It's your evidence, your context, and your impact. Thank you.
Okay, I noticed a typo in that last slide. Okay, so that gives you, I think, a fairly succinct description of gLocal. And just when you hear being talked about where are these entities where synthesis is going on that are considered JBI, and all the red dots, of course, give you an idea where those are. And you can find ourselves on that map as well. And of course, you saw this model referred to in the executive director's presentation or and this pragmatic approach to implementation, you won't hear much today about implementation, but we do a lot of synthesis work, more synthesis than implementation, but it only stands to reason that when you synthesize, you bring together a body of literature on a topic. And when you bring together a whole group of studies, it adds to the strength of whatever it is you're looking at and what's known about it. And once you find that out, then the next logical step, of course, would be implementation. And so this is one framework to consider in doing implementation work. And one of my colleagues presently is doing well, actually, it's a randomized control trial. They had done a review on interventions related to intimate partner violence. And actually, in the process of doing that review, found an instrument that they thought was really had a lot of merit. And so decided to actually take that and implement. And they're probably 3/4 into the study. And so by this time next year, the study will be complete and the work will be published. And so that may well be a topic, depending on what, there's themes every year. And so, but usually the themes that are put forward, most of the synthesis and implementation work that's going on can fit. But just to give you some idea of, and that in terms of an implementation framework, we aren't required to use any particular, but this is one that they offer. And then this is really just to reinforce the points made in the video. And I introduced you earlier to myself and my co-PIs, and we received funding through the SPORE Evidence Alliance. So the Strategic Patient-Oriented Research Evidence Alliance, which is a national network devoted to synthesis work, not only doing synthesis work, but also working with entities like ourselves to do projects. And so the idea for this project came from David and Rochelle. And so I was honored to have the opportunity to be able to work with them. And also on the project, Nadia Steck, who's the research associate in our JBI entity. And then we had Alyssa Barker as research assistant, Ali Hamoud, who's with us today. I don't believe Alyssa was able to, Grace Magro, and Christy Hancock, who was the librarian at the Maritime Spore Support Unit, but has since taken a position in British Columbia. But certainly I don't know that Christy was able to join us today, but if you are, Christy, just let us know, because that would be great. And so the topic, of course, that we're looking at is home care. And when we put together the response to this study opportunity, that being David and Rochelle, of course, were very well. It was subsequent to them actually being the care providers for, in David's case, their dad, and of course, in Rochelle's case, spouse, who cared for provided home care, and they will talk shortly. You will hear from David, who will share their story. And so certainly before ever providing or being caregivers, like any of us, they had a perception or an idea of what that might be like. And then as they lived it, the perception of what that might be versus what it wasn't necessarily what unfolded. And we all know that the proportion of older adults, not only in this land, but around the world, is growing. And the care needs, many, in fact, most older persons want to remain at home for as long as possible. And so in order for families to do that, certainly services and supports are necessary. But then the other, of course, in order to deliver those, takes staffing resources. And so there's one thing to provide an individual to deliver care, but the other thing that's of high importance is that there be a match between the skills and abilities of the person coming in to provide support and the needs of the person that they are coming in to see. Continuity, we've known this for decades, the importance of continuity of care, because when the care provider and the client and family know each other, stress levels and worries are minimized. And so in doing this work, which was called Models of Home Care and Their Characteristics, we have naturally, of course, looked within our own country. And then we wanted to look at other countries with, naturally, no two countries are exactly the same, but we essentially were focused on countries with similar, that being publicly funded home care. And so we selected the UK, Denmark, Sweden, Australia, and New Zealand. And we were hoping that we would find evaluations of models or programs of home care. We did not find a lot. Probably the one country that had actually conducted at 5-year intervals evaluations of their program of home care was Australia. And of course, we were also looking for the level of integration of health and social care systems, because they need each other. And then just a little bit about how we went about this. Of course, it's a scoping review that we did conduct. And JBI has a set of methods for doing so. So we followed those methods, and I won't go into detail on that. But first, of course, naturally, we had to establish searches had to be conducted, though you see the databases that we used. And then once you have a data set of titles and abstracts of published studies, then there's a screening process. We had a list of criteria for doing this work. And so then 2 individuals would screen each and every title and abstract, and then decide yes or no to include. And then, of course, any title and abstract included, we then looked at the full text of that included work, look again against the criteria, and all those papers that met the inclusion criteria then moved on to data extraction and analysis. And so just to give you a little bit of idea of how much information we looked at, so you can see the total number of references, and among that 8,000, the number of duplicates that we found. And so then the number of full texts that we went on to review. That means reading the studies in their entirety. So when all was said and done, there were 14 um, papers that we saved from that search of databases. And so the other thing that we did was also look at gray literature, because many countries, including our own, and in our own country, you have 13 provinces and territories, and none of them really do exactly the same thing. And so we knew that when you go to government websites, particularly websites related to health and how that's delivered, looking for information particular to. And so we have 2 slides here that are a bit busy, but we just wanted to give you a little flavor of what we looked at. And of course, we also did that not only in our own country, but in the other countries that we included. And so what we were hoping, you always, before you start something, have some aspirations as to what you want to come away with. And again, I don't know why I thought this, but I did have a sense that there actually would be, I guess, sort of named programs or something reasonably generic so that it could be all encompassing, but that in terms of home care, how that I anticipated it being packaged rather, let's say half a dozen sentences that really pull together what home care looked like across all the places that we looked. And so I guess the short answer is I didn't find those neat packages, but if you keep looking, you can, and I think, yeah, I won't go down that rabbit hole at the moment, but if usually after looking at 2 or 3, whether they be published studies or pieces of gray literature, we were able to get what I think is a fairly accurate sense of what it looked like in these countries where we looked. And of course, who did we have in mind that might be interested in this information? There you go. Okay, so now for the most interesting part of this of the program, I believe. I'm going to turn this over to David, and David and Rochelle are a team, and so they will share their journey as caregivers and recipients, of course, they and their family member of home care. So David, take it away.
Thank you, Marilyn, and thank you everyone for being here today. My late father, Jack Litvack, had Parkinson's disease and eventually dementia. And we made the decision early on that it was very important for us to keep him at home. His Parkinson's required regular physical activity to mitigate the effects. And as his dementia advanced, he would require cognitive stimulation as well. But of course, the most important consideration was to keep him in a familiar environment surrounded by his favorite things, which I really hope included us, but we'll see. We did not have confidence that he would receive the necessary activity in an institutional setting. And while we were able to provide much of his care, it was the province of Manitoba's home care programs that made it possible to keep him at home as long as we did. That said, the inadequacies of the government run home care system became apparent almost immediately. But the key to the success of our care plan was the Winnipeg Regional Health Authority, WRHA, self and family managed care program. Though I do need to insert this caveat that my father passed away just before COVID, So I cannot speak to the efficacy of the program post-COVID, though what I'm hearing is not particularly promising. In the end, however, we were able to keep him home until he was admitted to palliative care, which was another issue entirely. But over the many years, we were able to learn much about the inadequacies of government-run home care programs, but also the challenges facing home care professionals in areas of training, recruitment, retention, etc. And so really what intrigued us in joining this project with Marilyn and her team was a simple question. Has anyone actually figured it out? My father's decline was quite gradual, and that dictated initially how much time he could spend on his own, how much assistance he required to get dressed and bathed, etc., and how much respite we as caregivers were entitled to. Eventually, he would require 24/7 care, and while we covered most of those hours ourselves, it became a question of division of responsibility with the home care workers. Early on, his needs were quite limited, as were the hours of home care available. For example, he would receive assistance getting ready for bed in the evening, but that would be the first hint of the frustrations to come. We had no control whatsoever over the schedule. The workers showed up when they showed up, ready or not. There were times when my parents were enjoying a nice evening out with friends and then had to rush home early for the service. In one instance, one of the home care workers showed up far too early, all dressed up because he had a date to get to. As time in his illness progressed, and we were granted more hours for respite and companion care, just keeping an eye on him, the lack of control became a greater issue. It almost became a game of roulette. Would anyone actually show up on time or even at all? And if someone showed up, who were they? Now, in fairness, we were sent some very good people. Some were experienced and trained, while others simply did not know what they were doing. In one case, egregious case, a worker showed up late asking if we had the quote unquote manual for her to work from. When we replied that we did not, she made clear that she had no idea what to do without it. Apparently, she was an employee of a contractor the province had hired to make up for staffing shortfalls. Throughout all this, there was simply no one to talk to. If a worker was late or did not show up at all, there was no one who would pick up the phone on the other end. If we had preferences or requests for what workers we wanted or not, again, no recourse. The more that we came to rely on respite care to enable us to run errands or attend our own appointments and meetings, the unreliability became untenable, and the ability to contact anyone became increasingly frustrating. As well, you are bringing strangers into your home. You are entrusting a vulnerable loved one to a stranger, often one in whom you may not have any confidence. Now, certainly we're not alone with this experience, and I've come across many news items of disturbing stories of patients with disabilities waiting for days, often in bed, for the care they needed. In Manitoba, however, we were fortunate to have options. At the time, we had friends and relatives in other provinces who did not have these options, and it certainly made a significant difference for us. Transferring to the WRHA's Self and Family Managed Care program transformed the experience for us. It was not without its challenges, but we would not have been able to keep my father at home for so long without it. So just a little background in the managed care program. The WRHA offers both a self and family managed care program. The family managed care program enables families of clients with assessed home care needs to accept full responsibility for their family member as, quote, a family manager. The family manager is responsible for coordinating, managing, and directing the services needed by their family member. Self-family managers receive funding to either purchase services from an agency or to employ staff directly following the completion of a formal assessment to determine the amount of funding. Reassessments are conducted on a regular basis by a WRHA home care case coordinator to enable adjustments to be made as the needs and services increases or decreases. Now, from an administrative perspective, family managers are required to set up and maintain a separate bank account, and this account is used solely for receiving and expending family managed care funds and are subject to semi-annual reports and audit reviews by the WRHA. Hiring family members is not allowed. Now, as I said, family managers can choose to hire an agency or to provide the funded home care services, or may choose to directly employ their own staff. If you do choose to employ your own staff, you take on the full responsibility as employer, registering with the CRA, employment insurance, workers' compensation, making required payroll deductions, etc. Though there are payroll companies that can help you with that. We chose to go with an agency, while hiring directly would have allowed us to have greater control over the cost and remuneration, in other words, not exceeding the funds provided to us. We felt that we had enough on our plate without the added responsibility and, frankly, aggravation of being an employer. The change, however, was immediate. We were the client. The agencies reported us directly, not the WRHA. We had full control. We demanded accountability, and we were uncompromising in what we expected from their staff. We would interview a number of agencies. Some were prepared to match the WRHA price points. Others were slightly above, leaving us to pay the balance out of pocket. At a minimum, however, the program provided a heavily subsidized home care program. That said, I have heard reports that for many in the system, even paying a small amount out of pocket added up and was beyond what they could manage, something that needs to be kept in mind. Originally, my father had enough mobility and lucidity that he only required companion care, someone just to keep him company, engage him in conversation, go for walks, etc. He was a classic movie buff, so he enjoyed educating them on the films of the 30s and 40s, but as his condition deteriorated, his needs became more complex, and the first agency we worked with simply did not have the personnel that could provide that level of care. It was at this point we became aware of the challenges the home care industry faces. Over the course of my father's illness, we go through 4 different agencies as their staffing problems became insurmountable. So I've mentioned what our expectations, so we'll just go through them fairly quickly. Over time, the care became 24/7, and we provided much of that. But for a few hours a day, we relied on the home care workers for much of the literal heavy lifting. So what is it that we expected? So first and foremost, technical skills, the ability to safely transfer and manage him physically. With Parkinson's, it became increasingly unsteady. There are techniques to get patients safely in and out of bed or chairs. When walking with him, it required focus to ensure he didn't fall. This required training in these formal techniques and a level of physical strength. We had a number of workers who quit because they could not handle the physical exertion required. And similarly, there are skills and training required for dementia care. We were very much relied on the home care workers to maintain his hygiene, to bathe him, help him dress, etc. But we also expected them to supervise his meals and to oversee his medications to ensure that they're taken properly, which became a challenge over time, and he became quite sneaky at it, frankly. In terms of physical activity, my father had to be active throughout the day to mitigate the effects of the Parkinson's and had to be stimulated cognitively to mitigate the effects of his dementia. We expected and demanded the workers to keep him active and stimulated throughout the day. Due to his dementia, he was inconsistent in his behavior and energy level. Nonetheless, we expected them to make every effort to keep him moving, even just walks in the building hallway throughout the shift. One of the more challenging tasks was to make the effort to stimulate him cognitively by engaging him in conversation and playing games. We didn't object to him watching TV, but insisted that some effort needed to be made to find programs and movies that would be of interest to him. Frankly, we had caregivers who would use the opportunity to catch up on their own personal watch list, often choosing movies that were just wildly inappropriate. Again, we were bringing strangers into our home. We hoped for basic respect of our property. We're not looking for housekeeping services, but if under their supervision, my father made a mess, we expected it to be cleaned up, especially in the kitchen and the bathroom. Surprisingly, that wasn't always apparent. The one very unique and frankly positive element, we could arrange through the agencies for the caregiver to drive my father to appointments or even just for a short outing. In return, we would pay for the mileage. For example, until the very end, my father would go to a local gym that had trainers who specialized in geriatric fitness. Not a insignificant amount of staff came through our door over the years. There is frankly no single profile of those who showed up. Some were trained home care workers or healthcare aides, though the training experience varied greatly. Some were retired nurses looking to keep busy or earn some extra income. They were generally excellent, but being retired had the luxury of being very particular about how many hours they're prepared to put in. Many were new Canadians. Some were shift workers for whom home care was a second or even third job. If a better shift or better hours were available elsewhere, that's where they would choose at our expense. Others were internationally educated healthcare professionals who were struggling to have their credentials recognized in Canada. We had nurses, doctors, even dentists. They were all very skilled and knowledgeable, but some clearly conveyed that the work was beneath them. And I can't say that they were being unreasonable with that. In our interaction with the agencies we worked with, it was clear that there was a serious problem with recruitment and retention. The best workers quickly move on to bigger and better, especially if they were finally able to find gainful employment in the chosen profession. One agency with whom we had an initially excellent relationship eventually began struggling to fill shifts. We could no longer make plans because we were not guaranteed that someone would show up on time or even at all. At least, however, unlike previously, we had an office to call and with whom we could coordinate. Often in a lurch, they would send someone unfit, and we would have to spend the entire shift supervising and assisting. The final agency we worked with gave an excellent presentation in terms of what they could offer, but in practice, they simply could not deliver. That said, my father's last caregiver was absolutely outstanding, but he was entirely a fluke. He was a highly skilled and experienced healthcare aide who was the victim of what could best be described as bureaucratic stupidity. He needed as many hours as he could, and this was precisely at the point where we had more than enough hours to throw his way. That worked out great for us, but you can't build a home care policy around luck and happenstance, though that seems to be the general trend of things sometimes. So in conclusion, just some thoughts. Like other provinces, the government home care system in Manitoba was inadequate. But in fairness, the WRHA self and family managed care program provided us exactly what we needed. That said, it would not necessarily work for everyone. We got a good look under the hood of the home care system and became quickly familiar with its inadequacies. Training isn't one size fits all. The skills for elder care, especially dementia care, are quite specific and in no way intuitive. The National Caregiving Strategy discusses remuneration. Simply put, if people aren't paid a living wage, they will look elsewhere and leave at first opportunity. Again, recruitment attention is central to the discussion. And elder care is not just about technical skills. It also requires both workers and managers to understand the people for whom they work. Far too often they condescend to or infantilize their clients, both patient and caregivers. But I think ultimately, despite some of the negative tone of my presentation, it was without this self-managed care program, we simply could not have kept them at home. And in the end, it was a successful experience for us. So thank you very much for giving us the opportunity to speak with you today.
I'm not quite as blunt, as tactful as Jack is, and I have some specific recommendations. Whatever we come up with, if you don't run it by the actual people who are working in home care, then the whole study is not worth the paper it's written on, because it may look good on paper, but it may not actually work. Hospital coordinators for home care. I don't know what goes on in the rest of the country, but in Manitoba, they try very hard not to give you home care, and they'll give you the very minimum, which is not adequate enough, and they need to be spoken to about that. One training does not fit all. You need specific training for specific types of home care. Somebody who can do companion care cannot look after somebody in a wheelchair or in a nursing home or whatever. Also, when you're speaking to seniors, please don't talk down to them. Most people over 80, well, not most, but a lot of people over 80 have all their faculties. They can look after themselves. They just need help with physical things, and they don't appreciate being spoken down to. Some of the best workers are people who work in personal care homes and who are moonlighting for extra time. And they know how to handle people with physical disabilities. They know how to motivate people. They're some of the best ones. Also, you have to pay them a living wage. We had people who had 3 or 4 jobs, and the loyalty was to whoever gave them the most hours, and that's not good. Those are just a few of the things that I found that were important. The training, I think, is the most important thing, is to have people trained to look after specific needs.
Oh, thanks so much, David. And that really, in Zoe's short video, probably one of the takeaways is context matters. And certainly you're sharing with us the story, as well as where you see some gaps of high importance. Lots of, yeah, thanks for that, because for those of you who may not realize, the 5th of June, David and Rochelle were here in Halifax, and we had a workshop with individuals largely connected to home care in a variety of ways. For example, managers. And also we had representation from the Ministry of Seniors and Long-Term Care. We had Alzheimer's Association of Nova Scotia. So just to give you some idea, we tried to have the audience, we individually invited people that we knew would be directly connected to home care, so that we could enter into a conversation with them. And and we had scribes for the portion of the program where individuals had a chance to come together in groups of 5 or 6. And so in addition to us doing this scoping review, we also have the information shared with us on the 5th, and of course today, to help us think about when we're writing about what we find, relating it to those that are living it. And because way back when I first started to work with David and Rochelle, and the more I listened to them and their experience, it spoke to me about how we're going about things. And that's, hence I'm using the term model. So the model being how we set things up and carry them out. And so what's the model that, you know, any particular jurisdiction is using, and the characteristics that make it up as a way to talk about, because by naming things is one way to help us. Well, okay, this is how things are being done, but if you continue to do them the way you've always done them and think that things will get better or change, we know that's not the case. So each time that I hear David and or Rochelle talk about their experience, and you know, in full disclosure, many of you that are joining us now know, but I'm also a caregiver. My mother lives with me and has dementia, so all kinds of challenges and parallels in my case, as with parallels to what David and Rochelle have shared. So I'm going to continue now with the rest of the slides, and because the first hour of the program is the sharing of information, and then we're going to get into conversation about what you've heard, and ideas and thoughts. And I'm really keen to, because I would argue that that's probably going to be the most valuable. Hearing about David and Rochelle's story and the conversation we eventually have, to me, will provide the most value for the event. So many of you would realize this, but there was a guidance document issued March, just a very short time ago, by the Canadian Home Care Association. And some of the points made in that, in the executive summary, and of course, and this is always the fact that home care is not enshrined in the Canada Health Act, whether we like to admit it or not, that's a powerful, the fact that it's not, to me, speaks to a lack of recognition of its importance as part of the healthcare system. And I certainly welcome to be challenged on that, but I've always felt that way. The second bullet I've already stated earlier on, And of course, the Canadian Home Care Association speak to the notion of an enhanced framework for integrated people-centered care, and the whole integrated, the use of that word in a sentence with healthcare, you see stated over and over again, but stating it and making it happen are different. And again, I included the next bullet because of its importance, merging healthcare and social services with interdisciplinary teams to deliver. So these are the, I guess you'd say, the highlights of this Canadian Home Care Association document. And they see home care plus primary care plus community services. They need to be hand in glove. But I think all of them do, because Rochelle's point just a few minutes ago about the folks that liaise between hospitals and home care, the nature and the quality of that liaising is of prime importance. And so one of this, in terms of our search, and relation to models of home care, British Columbia, and in particular the region known as Fraser Health, instituted this Home is Best. And they did that, as you can see, back in 2014. And then subsequently, it was expanded. And so what it consisted of, acute care medicine, primary care, and community care under a single executive lead. So that englobes what the model is in Fraser Health. And because of the, I guess you'd say, the interest, participation, and overall positive response, then the Ministry of Health, their action plan over the years 2017 to 2021 was to strengthen home and community care for seniors. And with a plan to, and I won't say that they necessarily instituted what was done in Fraser Health, because going back to context matters, I would say, and I'll move to the next slide because you'll see there are 61 geographic health service region areas across BC. So of course, every one of those areas would have had services that varied. And so what you can do, you do what you can with what you have. But the overall desire was that it models somewhat the home is best. The other thing that I noticed in our read about home and community care in BC was I would say, health promotion or prevention strategies that in lockstep with working on home care delivery, strategies geared towards keeping the population as well as possible, as long as possible. And in other words, reducing or lengthening the time that people can go without needing services, or needing fewer services. So this HealthLink BC and the Office of Seniors advocate to build BC's Aging Well strategy. So always in the background of everything is this Aging Well initiatives that BC is providing for its population, with the idea of maintaining health and independence into their 60s, 70s, 80s, and beyond. And some of the other services that they are attending to, once again, to think about the overall health of the population and building and maintaining that, and instead of being downstream all the time, fishing folks out who are in deep trouble, the further upstream that you can be instituting initiatives that are going to support individuals to maintain and or improve the health that they presently have. Alberta, as recently as a year ago, they, I guess you'd say, renewed their Continuing Care Act. It is publicly funded, means tested. Again, you see their aims: assist people to remain well, safe, and independent, case manager assessed, and the option for client self-management. And you heard David talk about that earlier. And so that's a pretty, I would say, succinct description of what Alberta does. Then you have Nova Scotia, and so funded by the Department of Seniors and Long-Term Care. And this is right on their webpage, what their philosophy is: evidence-based, person-centered, home first, care where you live, nursing services, long or short, and home support. And you can see nursing services come via either VON, the Victorian Order of Nurses, or Nova Scotia Health. And support services are contracted from home care agencies. And as you can see, means tested. And I'm going to invite Karen Curry and Ben A, who are with us and experienced in the provision and working within the home care system here in Nova Scotia, to certainly comment on the information on that afterwards, after I finish the presentation. And something we didn't set out to do, but it was, I would say, everywhere in the literature, when you're looking for a model for a province or for a jurisdiction, it became clear that whatever the model was, I'm guessing there were lots of gaps because of the number of, I call them submodels, but you had, in these 5 initiatives, these were published in 2019. And so, for example, in Calgary, they have this integrated home care geriatric consult team. And so obviously the consults needing to be done in a timely way wasn't happening. And so this was instituted, but not really connected, in other words, integrated, if you will, to the system. Then we came across Winnipeg Regional Health Authority between 2014 and 17, this partnership for patients with complex needs. So there was clearly, and I'm guessing, when we saw this complex needs, likely these folks were ending up in acute care because obvious needs that weren't being addressed in the community setting. And so, and unfortunately, it seems like at the end of 2017, it did not continue, and it was replaced by what they call rapid response nursing and priority home. And I wasn't able to determine if that is still the situation in Winnipeg Regional Health Authority. Then there was Toronto House Calls, a community-based interprofessional team, Unity Health and Sinai Health. So here you have 2 big health delivery entities in Toronto, Greater Toronto. Again, seeing that there are gaps, and likely because it's hospitals that are initiating this, they're trying to keep hospital beds free of individuals needing long-term and in many cases home support in order to have their needs met. And so coming up with, and these of course all represent, they're like stopgaps. They aren't integrated into existing programs. And when they aren't continued to the point where they are integrated and become part of home care, it's kind of great while it lasts, but you never, if the intent or the gap that these submodels are filling often is time limited because they've gotten funds to do it for a certain window of time. And so if funding for the program overall doesn't somehow incorporate this or integrate this, then people only benefit for a short term, and then the original challenge persists. The University of Toronto Family Medicine Community Health Teams. Now I can see a university initiating this because of course it's going to be a great clinical opportunity for their students. But again, if it's not integrated into the system, the home care system program or model, then there will be an ebb and flow of activities like this. And you see the same with the universities, McGill, along with their teaching hospitals in Montreal. So yeah, the publication was 5 home-based primary care initiatives. And so we do know that primary care is challenging in every jurisdiction in this country. And so these initiatives sprout up. Anytime there's a gap, you get this sprouting of, and I'm not saying don't do it, but trying to get sustainability with any of them seems, yeah, to be a bit of a dream. And then, of course, just more, the SMILE program, Seniors Managing Independent Living in Ontario. And I know this program has gotten quite a bit of, coverage. I've been reading about it for quite some time. And I actually thought, and Karen, you can address this later, I actually thought that Nova Scotia was looking to pilot at one point, but it probably was just something being discussed and never really went any farther than that. So moving on to Denmark and Sweden, and of course many of you on the call will know Denmark and Sweden, the Scandinavian countries as a whole, certainly are looked to and have demonstrated considerable success in, in integration of the delivery of care, no matter the setting. Often referred to across these countries as the Nordic model. And I would say one of the most important things that underlines approaches is the notion of no older person being in poverty. And so if the personal resources that all individuals have are adequate, then it raises the likelihood of them being, their general health overall being, being as good as possible. And so Denmark describes themselves as being broad, inclusive, and individualized, universal, publicly funded. They're considered to be one of the best countries for seniors to live. Their policies preserve well-being, independence, and dignity. A robust welfare system And I made the point about financial security, because in the absence of that, just the psychological burden in the absence of adequate finances, its impact on health can't be underestimated. Comprehensive health care and long-term care. And of course, talked about the importance of prevention earlier on. Now, Sweden, although they, I would say, mirror Denmark, there is, and they are clear about this, that the depth of resources are more targeted to the most frail. Then Australia, and this goes back, I would say, in the 1990s, their model is known as consumer-directed home care. And I don't need to read everything here for you. Due to the duration of this program, I saw at least 3 evaluations of it. And they were very attentive to the feedback and evaluations and made modifications to their program over time. And as you may have guessed, one of the major challenges was, David made the comment, self-managed isn't for everyone. And as you can imagine, if I'm the client, depending on my cognitive, physical, general status, I may well not be able to self-manage, nor have someone who can take it on for me. So of course, there needs to be the option for not only self-managed, but agency managed, for example. And the last bullet, modifications that they've made are largely related to providing information and support required by clients to self-direct. And that was probably, there were always areas for improvement, but that one, the modifications made over time, was consistent in refining the supports necessary for people to be able to participate fully. And then this was an interesting study that we looked at, because in the Canadian Home Care Association, they talk about the importance of context and how important all the things that need to be addressed. But in other words, there's not going to be a one size fits all, and there has to be that ability to adapt. And so this work was carried out in one part of Australia, so with the Indigenous people of Central Australia. And for them, it was essential that they have community control and cultural comfort. And they wanted a family model. In other words, all of the care for the older person unable to care for themselves, they wanted family and community members to get the training to be able to care for their members within community. So this older people's program was built exactly with that in mind, and bringing the training into their community and having the people learn how to care for their people so that they could live out their days within community. New Zealand, again, I don't think anything I need to, I'm mindful of the time there, it's 1:05 already. I believe I don't think I need to address anything further there. The UK, again, a publicly funded system. They also have a Cash for Care program, which they've had for quite some time. Now, they fund home care via continuing if you are assessed to have a primary health need. And that sort of, because of course your social needs can be I would say you wouldn't necessarily, now many older people have at least one chronic condition, but sometimes it's the general physical decline that comes with aging. And so if there isn't a particular diagnosed health need, it makes me wonder about them meeting that criterion. Access to publicly funded social care is both means and needs tested, and those deemed to have access may be required to contribute. And cash for care, social services, an individual is assessed as needing. Characteristics of home care models. And so in the Canadian submodels, the characteristics we noted there were led by a physician or a nurse practitioner, integrated with other health services, leveraged home and community support. They had regular meetings and after-hours support. Again, the Ontario health teams, we had an Ontario individual attending on June 5th with us. And the general comment was the Ontario health teams are working towards integration of medical health supportive community and institutional care in one system. So a work in progress. But interestingly, back in 2009, Forbes and Edge, who I believe are or were at that time at Queen's University, they had published a commentary and advocated for a national home care framework. And so the first national that appears out of the Canadian Home Care Association is just this year, and also advocated for timely access, consistent relationships with providers, and that rural settings and their solutions may need to be particular. Then, of course, in BC's integrated care, the characteristics, integration, continuity, autonomy. And then the Swedish and Danish models, the importance of users in relation to choice and control, continuity, flexibility, client knowledge of available services, knowing the client, respecting, person-centered. Could hear a lot this in David's and Rochelle's comments today. And then Denmark and Sweden, continuity, coverage, access, et cetera, et cetera. So no surprises to us there. Then, of course, in the Australian model, flexibility and information needs, those were the top challenges experienced by individuals using this model. Autonomy and choice, that's what they were aiming for in the model. Self-management supported. So administrative aspects were less appealing. Choosing a support worker, a definite benefit. Self-reported, improved well-being. Self-identity, UK cash for care, similar assessments of benefits. And that's a wrap. So I think I will minimize that and move my teams over. And yeah, this is our opportunity now to have a conversation with one another. And before meeting today, I'd asked Karen, my colleague here at the School of Nursing, to open a conversation with us because of having listened to David and Rochelle, their experience, and some of what they believe we need to be attending to. And having worked in the system and been working in the system at the present time, I'm sure that as you've listened to everything so far today, lots of stuff has gone through your thoughts, Karen. So please share with us.
Can I just say something before
Yes.
Karen starts? You said mentioned that it's means tested for getting home care. Manitoba doesn't have that, but mean testing in other organizations and whatever, it always shows that the top 1% of the people show the lowest income because their home, cars, travel, business, entertainment, everything is written off as business. And the average person who gets T4 slips, they don't have all these deductions, and they may have a special needs child, or as you're looking after your mother. So I don't think that means tested is, I would go for not that, to be honest about it. And something that came up on June the 5th was A1 being helpful. And the last thing a person who's not well needs is a robot. They want a person and the contact. Those are just a couple of things that I thought of.
Thanks for that, Rochelle, because we see that like in the the use of robots that's been coming up for quite some time. And yeah, I think we have a ways to go before maybe if I had one now in my life, as the years go by, I could that could become part of my what would I say, household world. But yeah, thanks for that, Rochelle. And I notice here, Rochelle, so I have to, you know how you get a notice of assessment from CRA? So I provide that notice of assessment to continuing care. So they see, well, yeah, I mean, your entire financial situation is laid out.
But there's you have a lot of, they have expenses or something that they don't know about, that you don't have all that disposable income that they think you have. And
Right.
you don't have the deductions of your home and unless you've got an office space, but it's just part of your home and everything else written off as business. So I'm sorry, I was just going to say I've come across that in other private schools and in other organizations where the wealthiest are paying the least because they have the smallest income.
And in terms of, I think the only, I'm almost certain every place we looked now, I'd have to go back and look at Denmark and Sweden. I'm not certain that I saw means tested there, but I think I saw it pretty much everywhere else. Well, and again, with the exception of Winnipeg Regional Health, and that would be the province, of course, as well.
We're not means tested.
There's an equity there.
Oh. I just wanted to throw that in before you started.
Yeah, thanks, Rochelle. That I might reach out to you and have, because I can see when we discuss what we find, that observation, I can't say that I've seen that in any of the written work so far. So I might get you to draft a paragraph that for us to work with when we talk about what we find, because we'll present what we find and then there's the discussion section. So what does it mean? So being means tested, there could be a mean to the means test.
Definitely.
Karen.
Great, thank you, Marilyn, for this invite. And I'll refer to my colleague and friend Benny, who is currently still working in home and community care. I've been away for 3 years since I've been teaching at Dalhousie, but staying connected to what's going on. But certainly the landscape in Nova Scotia has shifted a wee bit, and there's been new programs and new models that are being tested since I left. So I refer that to Benny. But My first thought, Rochelle and David, thank you so much for having the courage to join into a research venture like this and sharing your authentic story to help get the word out, to help make improvements, because I think hearing the stories and is what's, and then partnering with research and policymakers is where the change needs to happen. But I've been, in my experience with home and community care, I started in the late 90s, and looking at the research and, you know, the scoping review that you've had, no surprises. You know, but yet continue to see the opportunities. And I think, you know, working as a registered nurse in home care over from the late 90s to the, you know, till 3 years ago, so over 24 years, seeing the changes in society, the aging population, the increased complexity of folks coming home, the growing need, and you mentioned a lot about integration and that partnering or bundling of services to support individuals at home. Certainly heard a lot about that, but didn't really see it in practice until the last number of years, probably the mid 2000s, you know, after 2010, 2020, there was a lot of work around that. So the thing about continuity of care, flexibility with options, self-managed programs, you know, picking, you know, who's going to do the work and the skill set provided. Now, most of my background, it has been in nursing. So my focus really was on home health nursing, or home care nursing, but also in some of my roles, really working across Nova Scotia and Ontario, looking at the different models of care and the growth of the community supports programs in Ontario. Nova Scotia trying to model some of that, but yet still very distinct and separate. So I think some of the issues that you kind of mentioned and came out in those reviews of models were the siloed effect, meaning, you know, the home care is kind of over here on the side doing its thing, and the acute care folks are doing their thing. Then you have the family doctor or primary care in the middle. And then from my perspective and when my work for many years, the home health nurse in the home helping to support individuals, many seniors with complex issues, and working with the unregulated care providers that were doing that home support piece, and seeing some of those gaps in from the acute care understanding what is being done in the home to the home health not understanding what's going on. So I think, you know, the more research and models of care, I think, you know, it's we're not there yet, but certainly have lots of, I think for the Fraser Health and the BC folks, when I often was doing programming or looking for evidence, I'd always go and say, what's BC doing? And particularly Fraser Health. What's Fraser Health doing? How can we integrate that? How can we take some of that to Nova Scotia? How can we integrate some of that work into our policies or into our practices? But seeing a barrier in some ways in Nova Scotia with the for nursing practice and home health, the unregulated practice, having the continuing care kind of as a gatekeeper, not kind of, they are the gatekeeper. And then that understanding of how can we integrate and work together. And often, even in a small province like Nova Scotia, the home care that folks were getting in Sydney was different than the folks getting in Yarmouth versus HRM, because of differences of understanding of us home health manual or home health or continuing care policies. So wasn't a lot of continuity from across a small province area. So, you know, I think it's really valuable to continue to have these conversations and to look at having the evidence to make some policy changes. And like I've been involved in some pilot projects over the 24 years, and again, some great ideas with virtual care and remote monitoring before the, technology of Zoom and MS Teams and all that stuff we're doing now. But just with the goal of keeping people out of hospital, and keeping people home appropriately, the right education, the right supports for families. I've seen a few of those not continue on in Nova Scotia, but I've also seen some changes, in terms of, understanding the roles. But the workforce, I think right now, is probably one of the more challenging when we're looking at that continuity of care. We're looking at nursing competencies for the different RNs and the LPNs in Nova Scotia from that perspective. And then the understanding of how do they work with those unregulated care providers that are coming in to do those respite visits or whatnot. So I guess when I'm looking at what your research and what the scoping review kind of showed, it's like there's no surprises. And shows that there needs to be more focus on home and community care, integrated, because even across Canada, like the different provinces have different, as we looked at, different models. So having a national home care strategy, but it all stems from the home care not being under the Canada Health Act. So I think that is one of the key areas, when you're looking at policy change, that then could provide some structure and some process to have some real change on the ground. But right now, today in 2025, I think it's health workforce. Many provinces, the home health workers don't get paid the same as they would if they worked in long-term care or a hospital. Nova Scotia does have that pay equity for their regulated staff, and I believe their unregulated staff, so that's a good thing. But across the country, that's not so. So there's challenges in safety, quality, those types of things. But I think coming back to the iceberg of home health, there's a lot of issues under the surface, and I think the Canada Health Act is the real big one, that until that changes, it's not going to really give some teeth to provinces, governments to really put meaningful change and money into the home and community care sector.
David and Rochelle, I don't think over the course of your caregiving, I would say there probably wasn't much contact with nursing services, was there?
Not with the home care, but Jack was in a program called Prime, and which was a senior health program, and it was fabulous. I wish everybody could have that kind of health care. They would pick them up in the morning and they would have a snack, but you gave up your family doctor, but not your specialist. They had a doctor, nurse, dietitian, physiotherapist, occupational therapist, everybody from the healthcare team. And they looked after them, they gave them lunch, and they had programs for them. It stimulated them, and then it took them home. But they also had an after-hours nurse who would come and on a weekend or in an evening, and that was really helpful. A couple of things I was going to mention was the only people that I haven't heard complaints about there's a couple of home care agencies run by Philippine women, and it's basically Philippine women. And I don't know what kind of training they have, but I have never heard a complaint about any of them. They seem to know how to look after somebody. And there's something else, senior moment, that I was going to comment on. There was one incident in Winnipeg. I can't stress the training, how important that is. We have a couple of residences with people with disabilities that have home care, and that gives them a little bit of independence. They sort of live on their own. And the workers went on strike for more money for a week, and every day in the paper there was a different horror story. The government sent in other home care workers to look after them. Nobody came till 2 o'clock to get me out of bed. I didn't get my meds that I was supposed to get. The meals were wrong. I didn't get this to this appointment. And so I think you need to have the training for different situations. And I can't stress that enough. Because some of our home care workers were the top ones in the agency, but they couldn't transfer Jack, or they took him to the gym, and I got a phone call from somebody from Jewish Child and Family Service that one of their workers saw that he was falling, and the home care worker couldn't handle him. They got him back into the car so he could get home. So they may be very good, and they may have graduated at the top of the class, but they may not be able to do certain types of things.
I think circling back to your question, Marilyn, sorry. What we had, we cobbled together on our own. There was nothing central that put this all together for us. We discovered the self-managed care program. We discovered Prime. We discovered that there are trainers in the neighborhood, the local gym that specialized in geriatric training. So again, it worked out for us, but I think if someone entered the program and entered into this on their own, again, it's a lot of, at least in Manitoba, it's a lot of do it yourself.
Wow.
Yeah, I think the other thing kind of, I think from what you looked at in terms of models of care for home care, I think even the language, right? You know, like home care, does that mean just personal support? Does that mean home care nursing? Does that mean home and community care? Does it mean community support? Like there's all kind of across the provinces, even in Nova Scotia, when you say I'm getting home care, it might be the nurse, it might be home support, it might be someone who doesn't have a designation, the language. But I'm curious if, you know, we think about home and community care mainly for the senior or complex care adults, but was there any mention about like continuum of like, you know, adults or children needing home health? And that's a whole other different, you know, specialty for nursing and for unregulated care providers that need training to take care of trachs and feeding tubes and whatnot. So that needs that whole integrated approach and team approach that takes time and coordination, right? So that's a whole, you know, but if we're looking at a national strategy, it would be from life to end of life, right? Like, so,
Right.
but I think most of the research is on seniors and home, not looking at complex or youth complexities or young adults that have complexities that need some services that might be provided in the home. So there's a lot of gaps in terms of service delivery for ages.
Yeah, we did as part of our criteria, we did limit it to the older person.
Okay.
So 65 and above.
Right.
And
okay.
for the point you just made, the majority of consumers fall in that age group. But you're absolutely right, Karen. There are needs across the age continuum. And, you know, I can think of over my years delivering home health. I mean, in any given day, it could be a newborn to, you know, a 101-year-old person that you may see in that same day. But again, the majority of, except when I was working with, even when I was working with public health, we did the Well Baby program, but the majority of our home visiting were with older people unable to leave the home often as well.
Yeah.
But that again could be any age group.
Yeah.
Anyone, since we're at the 1:30, I want to make sure if there's other individuals that had thoughts that they wanted to share just in response to any of the conversation, any of the information shared. Here's your opportunity.
I think on June the 5th, I think was Ali who commented about different ethnic backgrounds needing different types of cultural training.
Yeah, Ali, please share your thoughts on that.
Definitely. So, so my grandmother, uh, she's been living in the Annapolis Valley for, I say, most of her life. So she grew up here, etc. But she comes from a Middle Eastern background. So she has dementia, and with her care, the support, the care team kind of find it hard to, I say, meet her standards when it comes to care, like meeting her, like, like her background. So some of them don't really know how to approach it, or like that sort of thing. So it's a little difficult finding someone that truly meets, I say, like her way of life and her lifestyle, because she 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 doesn't want to change the way she lives, I say, like on the day-to-day basis. So having someone come in, kind of adopt and apply their own beliefs onto hers is not something that's easy for her and easy for us as well. So that comes with everything, like dietary restrictions, just a way of life in general, and it touches on every single aspect. So yeah, good point. And yeah, so I believe it's an issue to focus on, but I believe that there are other like priorities at the moment, kind of like providing adequate care. Because like in the Annapolis Valley, the like the amount of care that we could, get for her is kind of limited to some extent compared to like HRM in Halifax. So yeah, that's just about it, honestly.
Oh, thanks, Sally. You make an excellent point because, I know that there are numerous individuals who part of the support they received is a meal preparation. And
Mhm.
so certainly naturally the client, they have the ingredients there, but if the person arriving has no understanding whatsoever of any sort of restrictions, or that could be they may well prepare something that just cannot be eaten by the individual. So
Exactly. And also, I do want to stress on the idea that it's not only hard for the client, but it's also hard for the care givers themselves, because when they go in, they don't know exactly what they're going to face. It's just like they just walk in the door and they're just surprised with whoever they see, with whatever situation they're introduced to. So I don't believe I'm not too sure if there is any training whatsoever that kind of prepares caregivers for when we're like preparing them into dealing with different backgrounds. I don't know if that's available or not, but I was just thinking, like, Nova Scotia or Canada as a whole is so diverse. Like we have, many, like in our population we have like so many backgrounds, so many ethnic groups, etc. So that's why I was like, is there a training for this or not?
now I haven't seen, sorry, Karen,
It's Benny. Could I speak?
yes, please do.
Yeah, and I want to thank you also for the opportunity of being here, and thank you for sharing your experience, Rochelle and David. I just wanted to, in response quickly to Ali, we do have policy around culturally safe care providing. So I think it's something that is on a lot of people's mind, but the main issue I believe would be in the continuity, right? So because trying to find that right person that match the right client and try to have that continuity makes it very difficult, because it's to his point, it goes both ways, right? It's sometimes difficult for the worker and for the client when it's a new person every day. So you have to re-explain the same thing. And we know cognitive challenge makes it even harder for our families, because they count on, someone is coming to take care of my loved one, but that person arrives, and then there is an issue in communication, and so it's so many pieces in that puzzle. And then I was hoping to talk after Karen, just to say a few things, if I may. So you mentioned
Yes,
the
please
SMART
go ahead,
program
Benny.
that was looked at in Nova Scotia. I do believe that I didn't know, sorry, that they had looked at it, but we there is the capable program that was chosen and implemented. So there was a pilot that's been extended. So I think it's very similar because it has a more preventative and proactive action to keep people aging safely in place. That might be something that aligns with what you were thinking about SMILE. I had the chance to work in Alberta where I was a care coordinator, and if I compare from both provinces, I think in Nova Scotia, one of the issues is that we have too many layers, and to Karen's point, definitely a lack of recognition of the home care setting and community setting. I think that's also a key point in making it more structured to have better integration and to be able to organize care better, because I know we have a shortage, but of workers, right? But at the end, if it's not properly assessed and if we cannot prioritize the people properly, this is where we fail the people, right? So when we provide care, so in Alberta, the way it was structured, it was that you were a care coordinator, you were doing the assessment, and then it was a conversation to see what type of service within the budget. I never had to assess people's means. That was just for the like when you direct your own self, I think they had to provide that information. But for the service that we would provide, it was always within a budget that was established by AHS at the time. And then if you had to go over that budget, then you would have to get approval. But it was very well structured. Like we maintained people in place with ALS. Like it was well organized. I miss it. Happy to be in Nova Scotia, don't get me wrong, but it's like that structure and that direct person that my role was to navigate the client and explain what was available and the family and try to really combine all of that for having the best recipe for that special person, because there is never all fit ones, right? That was really enjoyable, I guess. And I see, Ali, you have your hand up, so I don't want to keep talking. Sorry.
No, it's okay, Benny. Feel free if you want to continue after Ali's comment.
No, exactly. If you have more to say, no, by all means, you can take your time. But I just want to highlight a few of the points that you mentioned earlier. So as far as I'm aware, I do know that within larger cities, there are more like, I say, opportunities to kind of have someone that meets your cultural background, take care of your loved one. But when it comes to rural Canada, like rural Nova Scotia, rural Ontario, etc., what can be done to support these families who are in need of caregivers who meet their cultural backgrounds within a community that's so, I say, like, rural? And in my opinion, I think there should be more funding within the sector itself. And then, once caregivers, see like more opportunity to make more income, this may push them to go outward into rural areas as well to help those communities. So I just feel like it's all interconnected. But I was wondering, what do you guys believe should be done within this with this case?
I guess, Ali, I'll jump in just because of the reading I did of the initiative in Australia. Certainly, it was Central Australia, so great distances from absolutely everywhere. I think maybe the closest city was something like 350 kilometers away, and it was really not a city, a town at best. And so it was rural as rural can be, and how important home care was, but how that community wanted to build it right there, but they needed people with background and expertise to come to them to build it. So that's one way to think about it, because I believe individuals know what they want and what'll work for them. And it's true, I realize no matter what community, not everyone will be of like mind as to what's needed. But I think as a group, they can come together to lay out, and no one program will be exactly what everyone wants, but I believe they can come to agreement on, at the very least, what they want, and that everyone can agree on. But I do believe that, yeah, building it with individuals who know what it means to be caring for someone in their home is absolutely essential.
Great point, sir. I definitely agree. Unfortunately, it's a bit more I say complicated than one would kind of assume. There are so many factors that go into it, and just thinking of it like from a basic perspective, it's not easy to meet everyone's needs within such a large geographical like area, right? So I mean, like I'm originally from Lebanon, and Lebanon is smaller than the size of Nova Scotia. So like when I think of Lebanon as a whole, like an entire country, it's easier there to kind of implement such programs because it's so small. But in Canada, when you're talking about like an entire nation this big, it's hard to meet these goals so easily. So as you said, people have to agree on certain aspects and kind of adapt to others. So yeah, it's not easy.
I want to acknowledge, I've forgotten about the chat, but I see Sarah, who's with us today, has told me about a scoping review on models of respite service for children and youth with medical complexity, which is certainly an important part. Well, every jurisdiction would have a population of individuals, children and youth with medical complexity. And Sarah's also provided a link to was that the report or the protocol, Sarah? The protocol. So it sounds like it's a work in progress. So keep us posted. Great. Thanks for sharing that. Okay, so we're at 1:45. We have 15 minutes left. Are there other things that have come to mind for individuals that, when you're thinking about home and community care, you've had these days where you're like, oh, if only, oh, if only. And both times when I've listened to David, and knowing as a home care recipient that when something's scheduled, how much of your life you've organized to be able to achieve certain things because you're counting on the service that's supposed to be here on this day between these hours. And, if it happened, once every 6 months or something like that, anyone's schedule can appreciate that. But when it's a regular occurrence, the havoc that it wreaks in so many ways is, yeah, it takes a toll, because individuals, first of all, they're caring for a family member. We know that the hours of unpaid care that families provide are in the billions of hours. And so the respite or the assistance that that's been set up is just so very important to each of the life of each and every caregiver. It's yeah.
You know what I think too is that I haven't in Nova Scotia, and I don't know if they do it in continuing care, but I think there is a lack of consideration for the caregiver and the caregiver burden. Because in most of the province, like I worked in Ontario, Alberta, and here, respite is always the one that we can solve the fastest, right? Because it's the less on the health piece often, it's the less important because it's not for the client who is the one recipient of the service, it's for the caregiver. And if you don't support the family, then the client cannot stay in their home. And I'm wondering if that's a bit of the key and where the lens should be changed a bit, because now that you're saying that, and maybe it comes also from a higher, a structure from the department, but if we were able to actually, prioritize based on the true needs, like I see, and I'm not saying that missing medication are okay, but like that's often, well, we cannot miss a pill. Well, we all know we forget all pills once in a while, and it's often not deadly. But sometimes the priority is put on something that might actually not be really the priority on that day. But how do you face when someone called in sick? Like it's all, as a system, I don't know to make it better. And then the last thing I would like to add around the robotization, etc. I think we need to look at it from a very innovative way and to allow actually more human contact. Because if a caregiver is in a home and have to wipe the floor or anything like that, it's time that's not spent on the human, right? So if you have a Roomba robot that's vacuuming for you, like that's, I think, allows for more human time because, now it's a machine who does that job. And then to go back to what Rochelle explained around that top of the class care health provider that could not handle physically, I'm guessing, the fall of the person. Like this to me also could be a place where we could have like a mechanical support, to allow, because physically, like I understand what you are saying, but the true reality of being a worker in a home, like sometimes the client doesn't want to be in a hospital bed because it's not as comfortable, and I understand, but if I come and move you every day on a bed that is not at the appropriate height, my back is going to go, right? And so you're losing continuity because now I'm hurt, and now someone is going to lose their visit because, someone has to call sick because they are hurt. So we have to really find a way to partner and have conversation around this. And even with Ali, when he was talking, I think it's more about like, if I meet you now and I'm assessing the situation for your grandmother, it's like, we have to have a way to ask what's really mattered to you. What is it from the cultural background that's gonna matter when we're gonna send person to provide service? Because that's only if we communicate better, and that communication is actually transferred to the team that's gonna come to help. That's only then that we can improve things, right? And it has to be built at the high level. But often, it's the first person that's contacted is continuing care, and they say one thing, and then you're contacted by VON. Often, like here, it's the unregulated person that do the admission. Like that's always blows my mind. So you don't even have a person with, more knowledge or more understanding of a system that says the first person that's going to come look at your house and say, what do you need, etc. So, I think we are almost doing it backwards. I would rather have service that start later, but actually have a proper meeting and proper discussion so that we can come to a place of, okay, this is what we agree upon. when David was explaining that they met with different agencies and discussed, I think that the only way to get something that's actually good is to stop to try to go fast. It takes a little bit of time to have the perfect recipe. Like, you know what I mean? You need to actually meet the people and really understand their situation. So then you can set up something that's gonna matter and make a difference. Anyway, I could talk for hours. Stop.
I was thinking, you know, Benet, when you made the comment about the Roomba, the robot vacuum, well, I have one, and of course, I cannot use it. Like my mother, her cognitive state, it's absolutely terrifies her. And as many times as I've tried to try it, yeah. So we have 2 levels. Now it's parked, it cleans the 2nd level, but the main level, we've got to do with the standard vacuum cleaner that she recognizes as a vacuum cleaner. It's about, I don't know, 40 or 50 years old. So she's okay with that one, but she's in distress for the day if we break out the robot.
I was
That's
just going to
interesting. Yeah.
I was just going to say that you made a very good point about respite for the caregiver, and I think that has to be a very strong recommendation. A lot of times the home care bureaucracy doesn't think that that's important, but you need care for the caregiver, and the caregiver needs some space and some time on their own, away from the person they're looking after. And even though you look at it as care for the client, you have to also look at the caregiver and make sure that they have the respite and time off that they need.
Thanks, Rochelle.
That was a good point that you made about the caregivers.
Yes, yeah, I know that
I always
there's.
say, I
Go
was
ahead.
just gonna say, I always told my nurse when I was the educator that without the caregiver, we don't have a job.
Yeah.
Just to try to make them really understand, right? At the end of the day, like, when I leave this home, I need to make sure that you're comfortable and you're supported to continue to care, right?
Yeah. Now I know that there are some programs in this country that they have at least piloted, and I don't know if they continued on an ongoing basis, is they have a caregiver assessment. And so it's, let's say, I'm going to say 5 or 7 questions that whoever your most responsible contact is for the services you're receiving, that they make an appointment. And I think it's on a quarterly basis, and they go over these 5 or 7 questions with you. And essentially it gives some indication of, in other words, how well things are going inside your household in your role as a caregiver. Now, what gets done with that information, I can't, I don't have any answers to that, but clearly the intent of them is to give agencies some sense of the level of distress that individual may be experiencing. And if it seems like it's high, then the likelihood of them being able to continue doing what they're doing puts the likelihood of being able to look after that person into question.
Yeah. In Alberta, we had to do it for anybody that was like 100% of caring for their loved one. Often it was palliative clients, and that would be our trigger to increase service.
Okay.
Because when it was palliative, the budget was not an issue because some way the system knew that it was short term, right? And so we had to do almost at every visit. I mean, at least every time you did a full palliative assessment, you had to do a caregiver burden. I think it was a few questions. I just found actually this week in Ontario, there is a self-assessment for caregiver.
Okay.
And so it's just a website. You can go on it and it follow the, prompts about like to assess yourself, at least to understand where you're at. And I really advise anybody that's a caregiver to use it. Yeah, I think caregiver needs to be heard better.
Yes. Okay. Any final comments or observations that anyone has? Just check the client center. So yeah, thanks, Karen. I was just taking a quick look at the chat to see if there's anything that I may have missed. Nadia, anything that
No, I think we addressed everyone's comments.
Yeah, I would just ask Benny if you would send me a link to the Capable program. I'm pretty sure I can find it myself online, but if you send me the link, I think I should.
I can try to do that. Do you want it right now? Or
Oh no, just at your convenience. You're supposed to be on a day off today.
Yeah.
Anyway.
Yeah, that one I will definitely. If you just Google Capable in capitals Nova Scotia,
Okay.
you can find the link to the government. I don't know if I will find the link from VON. It's a program, I think, from the States that's led by occupational therapist.
Yeah.
And it has a nursing component as well. But it's really, really interesting. It's I think it should be like almost the paramount, like, everybody should get triage through Capable.
Well,
right?
I want to examine it fully because, of course, I worked in the extramural program in New Brunswick for a decade, and certainly seems to be lots of parallels. So I want to take a closer look and see. Anyway, at this stage, I would like to thank each and every one of you for participating today. I know that people gave of their time, and in your case, Benet, part of your day off. Karen, you added it onto an already full day, and all my colleagues who were present. So thank you so very much for the time you've given, for your participation. And it's enriching the work that we're doing. And I don't know that thank you's enough, but it's all I've got.